Hello everyone, welcome back. Today I'll be covering ankle block. Start off with an introduction, the advantages of ankle block, indications and contraindication, anatomy including the landmarks of block, the choice of local anesthetic and summary. Now let's get started. As an introduction, an ankle block represents a regional anesthetic technique designed to provide surgical anesthesia for foot operation. It is principally an infiltration block. This block provides reliable anesthesia for foot surgery in patients with multiple medical problems. This block is devoid of any major physiological consequences that may be associated with axial or more central blocks. The advantages of ankle block include 1. Easy in terms of technical. 2. High safety factor with minimal side effects. 3. Near 100% success. 4. Typically does not require multiple injections. And number 5. Can be taught to the relatively unskilled. Number 6. The most important is ankle block can be life-saving by avoiding the risk of general anesthesia in a very ill patients that having a foot surgery. Example, toe amputation, debridement. Indication and contraindication. Many types of foot surgeries can be carried out with ankle block including bunionectomy, arthroplasty, osteotomy, and amputation. Ankle block can provide analgesia for fracture and soft tissue injuries and gouty arthritis. It can be used for diagnostic and therapeutic purposes with spastic equinovarus and sympathetically mediated pain. Ankle block should be avoided in patients with local infection, edema, burn or distorted anatomy with scarring in the area of block placement and in procedure that require proximal high-pressure tourniquet, whereby the blocks will not provide relief for the tourniquet pain. Regarding anatomy, familiarity with the anatomy and innervation of the foot allows for a more precise localization of the nerve around the ankle, resulting in a higher success rate. 5 peripheral nerves provide sensory innervation to the foot and are relatively easy to block at the ankle. 4 of the nerves are branches of sciatic nerve. These are posterior tibial, deep peroneal, sural, and superficial peroneal nerve. The 5th nerve is the saphenous nerve, which is a sensory branch of the femoral nerve. With the exception of the saphenous nerve, an ankle block is a block of the terminal branches of the sciatic nerve. This picture illustrates the nerve that supply the plantar region of the foot. So the deep peroneal nerve supply the first web space. The plantar nerve that consists of medial and lateral plantar nerve innervate the sole of the foot that arise from the tibial nerve. The sural nerve is a cutaneous nerve, provide only sensation to the posterolateral aspect of the distal toe of the leg and lateral aspect of the foot, heel, and ankle. The second figure shows the sensory innervation of the medial aspect of the foot. We can see the saphenous nerve innervates the middle portion of the leg and the foot. The calcaneal nerve, especially the middle calcaneal nerve, innervates the plantar medial heel. The superficial peroneal nerve carries sensory information from the anterolateral aspect of the leg and the greater part of the dorsum of the foot. And lastly, plantar nerve supplies sensation to the middle 3 toes and the middle aspect of the 4th toe. Guarding technique. Number 1. Materials. Appropriate resuscitation equipment and medication are near. Surgical prep, sterile towels and gauze, sterile glove and mask, marking pen, 3 10 ml syringe, 3 25 gauge, 3.8 cm needle, 18 gauge needle, and local anesthetic. Number 2. Technical consideration. After placing the patient in the supine position, the entire foot should be prepped using an aseptic technique. If positioning issues persist, rather than prone the patient prior to blocking the posterior tibial and the sural nerve, the lower leg can be placed in a padded support or elevated by an assistant. The posterior tibial nerve and deep peroneal nerve are blocked first to reduce the onset of time of complete block. Also, subcutaneous injection for the superficial blocks will distort the anatomy, potentially causing delay. For posterior tibial nerve, it is the most important and most difficult nerve to block to ensure adequate surgical anesthesia. The tibial artery pulsation is palpable at the space between the posterior border of the medial malleolus and the medial border of the Achilles tendon. A 25 gauge 3.8 cm needle is inserted inferiorly at about 60 degrees to the skin immediately posterior to the artery, penetrating 1 to 1.5 cm. Following negative aspiration, 3 to 5 ml of local anesthetic is injected. The needle is pulled back to the skin and redirected toward the great toe. Following a negative aspiration, an additional 3 to 5 ml is injected. This fan technique is used to increase the success rate. This figure illustrates the anchor block for posterior tibial nerve. As illustrated, the marking at the posterior border of the medial malleolus, the needle is inserted inferiorly at around 60 degrees to the skin, immediately posterior to the posterior tibial artery. Fanning technique can be used. For deep peroneal nerve, the deep peroneal nerve and dorsalis pedis artery lie between the anterior tibial and extensor digitorum longus tendon. The nerve usually lies just lateral to the artery, which is used as a landmark. The skin is entered immediately lateral to the artery with a 25 gauge 3.8 cm needle. The needle is typically 1 to 1.5 cm deep to the skin. After confirming with a negative aspiration, 3 to 5 ml of local anesthetic is injected. Skin blanching on injection should not be observed as this indicates a superficial injection. This figure shows the landmark for deep peroneal nerve. You can see number 3 medial malleolus, number 4 lateral malleolus, Number 1 is extensor hallucis longus. Number 2 is extensor digitorum longus. Again, it lies between the anterior tibial and extensor digitorum longus tendon. The nerve is usually lateral to the dorsalis pedis artery. Next, regarding sural nerve. It is blocked by inserting a 25 gauge 3.8 cm needle lateral to the Achilles tendon at cephalad border of the lateral malleolus. 3 to 5 ml of local anesthetic is injected superficially posterior to the lateral malleolus in a field-like distribution with the goal of creating a ring of anesthesia once the superficial and saphenous nerve have been blocked. Again, this figure shows the sural nerve block is done lateral to the Achilles tendon at the cephalad border of the lateral malleolus, thereby create a ring of anesthesia. For a superficial peroneal nerve, placing a subcutaneous ridge of local anesthetic from the anterior tibia to the lateral malleolus blocks the superficial peroneal nerve. A total of 5 to 10 ml may be required to cover the 5 to 7 cm that is necessary to anesthetize all the superficial fibers. At the same area which was previously anesthetized during the deep peroneal nerve block can be used as an entry point for blocking the superficial peroneal nerve. Again, this figure illustrates the superficial peroneal nerve block. There is a placing of subcutaneous ridge of local anesthesia from the anterior tibial to the lateral malleolus. Regarding choice of local anesthetic, the duration of surgery and the required duration of post-operative anesthesia are important considerations in the selection of local anesthetic agents for ankle blocks. Long-acting preparation, about 0.5 to 0.75% bupivacaine and 0.75 to 1% of ropivacaine are commonly used. Commonly used intermediate-acting preparations include 1 to 2% lidocaine and 1.5% mepivacaine. In conclusion, regional anesthesia for foot surgeries can be achieved by blocking the 5 cutaneous nerve of the foot at the ankle level, a procedure known as ankle block. Similar to general anesthesia, ankle blocks helps in achieving a high-quality pain relief while reducing the need for opioids and increasing patient satisfaction. Ultrasound guidance has enabled precise and selective delivery of ankle blocks. However, the success rate of image-based techniques are controversial compared to conventional landmark-based technique. Therefore, the landmark-based technique is still widely used. Yay! We have reached to the end of this video. See you in the next one. Take care and bye.